All right, so like we mentioned before, I'm Chase. Thanks for coming out today. I thought a lot about this particular class and how we might make it user-friendly for y'all, as well as very user-friendly once we get started in the office on Monday morning, right? The biggest hurdle I think we have as practitioners is we go to conferences sometimes, or seminars or workshops, and we get all this great information, but yet we don't know how to easily assimilate it into our day-to-day practice once we get going again. And so as a workshop, this particular goal, or this particular class, my goal is to try and help you be able to implement things easily into what you're already doing. So we're going to talk a lot about neuroinflammation, neuroinflammatory conditions, and we're going into the conversation assuming that you know what a neuroinflammatory condition is. And we're going to talk a little bit about that and hit some of the high-level stuff, but I'm not going to go down to the deep dive of interleukins and tumor necrosis factor and cytokine metabolic activity in the immune system. We're just going to let that go for other CE level classes. Today will be more of, hey, how do we identify this in a patient? How do we do something with them? And how do we create change in their lives so that they get the outcome they're looking for, and that you, as the practitioner, can affect the change in their life that we want to accomplish. So that's going to be our goal. And there's hopefully going to be some interaction. You can kind of think of this maybe like even Sunday school class or something. I'll ask a question, you can talk to your partner, you can talk to me. It's perfectly fine to do something like that, right? Please don't just sit there and feel like you have to be quiet and blank-faced and go to sleep in the middle of the lecture. Yes, ma'am?
Do I have neuroprogenics on that?
You do, yes.
Can we go ahead and open that up? And
sure.
So everybody, if you would like to take some neuroprogenics.
So we're going to pass a bottle of neuroprogenics around. Feel free to look at the bottle, check it out, take some if you'd like. Take one, pass it on. Y'all know the drill. You've been in the 60s before. Take one and pass it on, right? So maybe this isn't quite as Sunday school as we thought. No, I'm just joking. So here we go. Neuroinflammation. We all know the brain is the most important organ in our body. At least our brain tells us that, right? So therefore, if we're having an inflammatory process and that process is affecting the brain, it's going to have outcomes that jack us up. And none of us want to be jacked up in our lives, right? They can be low-level jacked up with symptoms like I'm tired, I've got fatigue, I lose my keys whenever I'm looking for them. Or it can be high-level jacked up like I've got neurodegenerative pathologic conditions like Alzheimer's disease, multiple sclerosis, Parkinson's disease, something like that, right? And it goes through the spectrum. But ultimately, once our brain starts to become inflamed, bad things happen. So very, very brief, 2-minute or less neuroanatomy lesson. Our brain consists of neurons and glia. Neurons, obviously, there's the electrical and chemical signaling of the body. That's how our body drives processes. We can think of it like the electrical diagram of the body, where we have a master circuit, it shoots down nerves, those nerves tell body parts what to do. About 80% of our body is sensory input, about 20% of our body is motor input or output, and it's this constant give and take of knowing where we are and what's going on and how it works in our life. And that's fine. The problem is our neurons are only about 10 to 15% of the brain. And so a lot of people think that's where that you only use 10% of your brain idea comes from. Because the other 85% or so of the brain is from the glia. And the glial cells are going to be the things that are like our immune supportive system in the brain that tries to keep the inflammation down, that tries to regulate the processes, that supports the neurons as the structure. And the glia, or the glial cells, when they start getting jacked up, that's where neuroinflammatory conditions really manifest and show off their skills of harming us. So there are different types of glia. You've got microglia, which, like I said, primary immune system of the central nervous system, and then macroglia would be these other sections here. These are great Googleable things to look at later, right? If you really want to go down the rabbit hole of what glia are and how they do it. But know that if neuroinflammatory conditions are present, it's not just a neuron-related thing. It's not just an action potential imbalance. It's not just sodium and potassium channels that are misfiring. That can be part of it, But a large aspect is going to be how is the immune system, how is the inflammatory system controlling itself, and what underlying metabolic activity is going on that in turn makes that not work well. And that's where we're going to spend most of our time today, through how do we identify this in a patient setting, and how do we share our knowledge amongst each other in our varying practicing styles. So in fact, before we even get going too much further, how many of you do some level of like blood test with some of your patients sometimes? How many of you are comfortable running a blood test? Okay. How many of you have never run a blood test on your patients and you just let someone else do that whenever you want it to happen? Okay, so a couple of us, we're just like, hey, they do the blood testy things, I don't. And some of us are like, no, I run blood tests, I'm comfortable with it. We're going to talk about some labs today that you might add into your testing to help screen for neuroinflammatory conditions. How many of you have patients fill out new patient paperwork? Everybody, state law, right? So all of us have some level of paperwork that's filled out. There are questionnaires that we could use, and we'll talk about some of those questionnaires to help identify neuroinflammatory conditions. How many of you do other types of functional medicine testing that's outside of laboratory tests like blood work? So maybe stool samples or hair analysis. Anybody do things like that or are familiar with it? Okay, we'll talk about a couple of those things. Now the hard part here is, for those of you who do lots of blood work but don't do functional medicine stuff, you probably don't want to be talking about that stuff. You want to know about what you do, right? And if you don't do either of those tests, you want to know about questionnaires and clinical stuff. And how many of you, just out of curiosity, are familiar with applied kinesiology as taught by George Goodhart and do a bunch of manual muscle testing and things in your office? Right? So some of us as well. That's what I do a lot in my office. So I didn't want to walk in and just say, here's muscle testing 101 on how I do neuroinflammatory stuff. But I also do a lot of blood work and a lot of functional labs. I kind of intermix a bunch of things. So I'm just going to kind of share what I typically do with patients, and hopefully it hits on an area that you're comfortable with in practice, so that Monday morning you walk out and you say, I'm going to start looking for this so I can help that person not develop Alzheimer's later. Or I'm going to do this thing for this one patient that comes to see me that has Parkinson's so that they can start getting a better outcome in their life. And so hopefully you can just grab what we're doing that's unique to your specific style. And if it's something you want to ask a few more questions on, like, well, maybe I do want to start running blood work and I don't know how to do that yet, well, let's talk about that as well, and we'll figure out how to make it work for you. Does that make sense? There we go. So there's a phenomenal paper. If you go to PubMed and you look up neuroinflammation, the devil's in the details, that has just some quotes that I thought were worth sharing. And so I hate reading slides, but I'm going to read these 3 quotes because I thought they were worth it at least. So, inflammatory responses that are centralized within the brain and spinal cord are generally referred to as neuroinflammatory. So that gives us our definition. When we think about neuroinflammatory conditions, we are talking about stuff that's within the brain, within the spinal cord. But just to kind of pull out some data from there, how many of you can think of a condition that does not involve some level of brain or some level of spinal cord? Can anybody come up with one real quick off the top of their head? That's a tough one, isn't it? Pretty much everything in our body is connected to something else, right? So therefore, when we have a neuroinflammatory condition, I want us to be mindful that it doesn't have to just be Parkinson's or MS or whatever, right? Neuroinflammatory can have reaching effects to other parts of the body that we may not have considered at first, and if we don't look for it, we may not see why we're not helping it. So number 2, the degree of neuroinflammation depends on the context, the duration, and the course of the primary stimulus or insult, right? Context, duration, and course are a big factor. If someone, so I remember being in a conference one time actually, and they talked about this guy who presented with Parkinsonian symptoms, so tremors that went away with activity, and then at rest, tremored again. The onset of cause was he reached into the back seat of his car, unbuckled the car seat, and when he stood up, he hit the back of his head on the door jamb. And Parkinsonian symptoms happened within the hour and didn't go away for a long time. So when we think about traumatic brain injury, it doesn't have to be this guy went and played in a football game and was knocked unconscious and 3 quarters later woke up, right? Sometimes mechanism of injury, that context, duration, and course of what happened, if we ask better questions, will help us identify the cause of what's going on with that individual. So, We'll go back to that. Remind me later if I don't come back to that guy to just talk about him again, because I'll tell you why it really caused it. Because the head injury was the provoking agent, but there was a different cause, and we'll talk about what that cause is later. Last one, the inflammation is mediated by the production of cytokines, so inflammatory hormones within the immune system. Chemokines, more inflammatory hormones within the immune system. Reactive oxygen species, secondary messengers, these mediators are produced by resident central nervous systems, glia, those microglia we talked about, and all these other things. So the glia is the big thing. If we can get that to calm down and work more efficiently, we do better. So, class participation time. Everybody look to your partner. Say hi, partner. All right, perfect. If you have a threesome, it's fine. Y'all can all, three it up, it's fine. What you're going to do is, over the next minute or two, you and your partner are going to come up with 10 different neuroinflammatory conditions and write them down, and we're going to see who can come up with the most without having someone else in the group come up with it. So go. You got a minute or three until I get my drink of water. So come up with some neuroinflammatory conditions. Don't be afraid to talk to each other. This isn't church. For those of you participating live on Instagram, go ahead and do the same thing. I'm just joking. Nobody's watching. Don't be afraid to write them down. All right, everybody's got at least 10? Almost. Getting close, right? Do another 30 seconds or so. While y'all are doing that, I'm going to eat a little bit of this. All right, let's go ahead and bring it back in for a second. Everybody had an opportunity to think about inflammatory conditions that they could come up with off the top of their head. We'll start over here with Lambert. Hey, Lambert and I went to college together a long time ago, so it's always fun seeing Lambert. He's one of my favorite people. He's on the verge of retirement, though, which is exciting but sad, because he's a great force for good here in the Houston area. So Lambert, you and your group, thanks for being here. I don't even mean to say that. It's not his group. It's his lovely wife, Lori. So Lambert and Lori, can you give me one of the conditions you came up with your neuroinflammatory stuff?
MS.
MS. Did everyone else get MS as a possible inflammatory thing? Anybody raise your hand if you got MS? Perfect. If you got MS, just mark it off your list. We're going to see who comes up with the most at the end. John, what's one from your group?
Bipolar.
Bipolar. Did anybody get bipolar? Oh, we got some bipolar conditions as well. Yep, go ahead and mark that off. That one didn't, it counts. But we're going to see how many unique ones we get. Dr. Nguyen, what's one y'all got from your group?
Chronic insomnia.
Chronic insomnia. Anybody get chronic insomnia? That's a good one. That's a good one. Good job on that one. And I don't know you guys next to Dr. Nguyen.
Dr. Brown.
Dr. Brown?
Alzheimer's.
Alzheimer's. Did everybody get Alzheimer's? Oh, we got some Alzheimer's. Go ahead and mark that off. That's a good one, though. So far we're up to insomnia, Alzheimer's, MS.
Did anyone say depression?
Not yet. We're not there yet. We're getting close. But Christy's group got depression. Did anybody get depression? Christy's group had depression. All right. All right, we'll go right up here. You guys. What's one you got on your list?
Stroke.
Stroke. Did anybody get stroke?
Yep.
Oh, they got stroke. That's good. We're good. We're brainstorming good stuff here. And Mr. John?
Crohn's.
Crohn's. Oh, wait. Crohn's? We said neuroinflammatory conditions. How could Crohn's, an autoimmune gut thing, show up on our list?
Gut affects the brain.
Gut affects the brain. That's brilliant back there. All right, Dr. Alyssa. No offense to everybody else in the room, she's my favorite doctor here. She's one of the top 2 doctors we have in our practice. I'm biased. She works with me, so her and I are together. There's only two of us, so she's one of the top two. She's number one though.
You don't have a good one. I have Parkinson's.
Parkinson's. Did anybody else get Parkinson's? Did we? Yeah, we got that one. All right, that's okay.
Anxiety.
Oh, anxiety.
Anxiety, panic attacks.
Anxiety, panic attacks. Anybody get those in their group?
Yep.
All right, good. So we're identifying stuff that we didn't think of at the beginning. This is great. And the last group?
Toxic.
I'm sorry, one more time.
Toxic metabolites.
Toxic metabolites. So if we had like heavy metal toxicity or exposure to chemicals or something, that could be neuroinflammatory. Exactly. So inability to clear things. So isn't that cool? There's some of those we came up with weren't on our list because maybe when we heard neuroinflammatory condition, we thought I can only look at Alzheimer's, dementia, stroke, TBI. And now all of a sudden Crohn's comes in out of left field and we're like, whoa, you're right, that does affect the brain. Wait a second, these sleep things, that does affect the brain. Wait a second, insomnia, or anxiety and depression, those are brain things too. So I tried just creating a small list of neuroinflammatory things that can be associated with it. So let's just dig through here for a second. We've got infections, medication side effects, chemical exposure, EMF exposure, gut-related stuff, viral stuff, autoimmune things. Like there's a lot of potential things that could tie in and trigger neuroinflammatory stuff. Because what is neuroinflammation? Glia freaking out and not being able to handle their metabolic load. And as that is accomplished, the body compensates through symptomatic expression. And that trigger doesn't have to be concussion in a football game. It doesn't have to be amyloid plaques. It doesn't have to be what we often default to when it comes to neuroinflammatory conditions. Even though that's a good place to start. So now tomorrow, Monday, when we walk into clinic and we do our case history and we start seeing someone that walks in that has Crohn's disease or ulcerative colitis or sprays chemicals for a living, we might say, wait a second, you could be having some neuroinflammatory stuff. And maybe you don't want Alzheimer's in 40 years, so maybe I can start helping you now. Right? Big deal here when it comes to the concept of neuroinflammation because it's triggered by all kinds of things. And we often forget that in our hyper-compartmentalized world where we have a specialist for everything. Oh, you have a digestive problem? Here's the GI person. Oh, wait a second. I can't look at your kidneys. I'm a GI person. Let's go send you to the nephrologist. Oh, no. Now we got to send you to neuro, right? The cool thing about what we do is we have an opportunity to step back and see the person as a whole. And yes, I recognize the importance of specialties. They're great. I don't want my child brain operated on by like a foot surgeon, right? I get that. Like I know there's specialties for a reason, but clinical presentations are often overlooked due to the awesomeness of specialties. And so we're attempting to step back and see the person for who they are and recognize that a lot of stuff can cause a lot of things in the body. And when we're looking at neuroinflammation, we can't discount other triggers besides head injury, stroke, and autoimmunity, which are the three biggest things we look at in conventional medicine. So, neuroinflammation. Is it all bad? I propose no. The people that wrote this really long paper propose no. There's a lot of evidence that says that neuroinflammation is okay if, let's go back to this, the degree of neuroinflammation depends on context, duration, and course. When you get a fever and you have an immune activity going on, you have positive neuroinflammatory outcomes that start being generated. You create interleukin-1 that does something. In fact, let's go to this one here. You create interleukin-4, you create interleukin-1, you create some stuff that triggers neuroprotection, tissue repair, enhanced plasticity, and reorganization. You recalibrate your life and you say, I should be better prepared for this in the future. Let's build up a little bit. But what if that duration lasts longer than what your body's capable of handling? What if the intensity of it is stronger than what your body can handle right now? What if something else goes on that your body cannot compensate for through its adaptive good things? Why is this not working? There we go. Well, if we lose the positive side and we stay in the process too long, we now start developing microglial priming, we get neurodegeneration, we get cognitive impairment, we get more swelling and tissue damage, we get problems that turn into pathologic conditions. So it's just like when you're jogging down the road and you trip on a pothole and you twist your ankle, we don't say, oh my gosh, inflammation bad, we have to never use it again. We recognize that, oh, our body is healing. It's going through its normal, natural, restorative processes, and as part of that, I'm going to support it in whatever capacity I can so that those inflammatory cytokines and inflammatory processes go down, but yet those restorative ones keep doing their thing, and now we have normal functioning leg later. Our brain's no different. When we do our good part, and it recovers appropriately, we don't have to stress about it because we're stronger for the next time we have minor head injury. We're stronger for the next time that we have minor infection, whatever it might be. It's when we are in a state where we cannot handle the barrage of damage that's going on in the body that we start shutting down and creating a tremendous amount of neuroinflammatory processes. Our cytokines go up, our interleukins go up, the bad ones, and it starts creating hard to change outcomes. For example, by the time someone gets Alzheimer's disease and is diagnosably Alzheimer's, it's really hard to start getting their brain to kick in well enough to start showing regression. Most of the time, you're trying to stop progression at that point because the brain is so inflamed and has been for so long that the window of recovery is so small that we're missing it. So we're trying to prevent us, our family, our loved ones, our patients from getting to this point. And if they're there already, how can we support them as best we can? Right? Step one, we got to learn to identify them. Right? That's why we did that whole activity a second ago where we had to come up with some quick things. And then we started looking out to where are these neuroinflammatory things coming from that aren't, I'm going to send you to the neurochiro down the road. Because a lot of neurologically inflamed stuff starts showing up, and we just want to look for it and find it. So, how do we identify it? We talked before about recognizing that there's a lot of cross reaction and a lot of overlap between neuroinflammatory conditions versus the traditional, top three that we think of. So today we're going to go over 4 main things, and hopefully this hits within certain areas of your particular practice, so that you can draw some of these things out and start incorporating them into what you're already doing. Because y'all do great work already. Y'all are brilliant people. The collective knowledge in here is amazing, and you have an opportunity to touch the lives of people in a really important way. But today we're just going to see what's this one clinical pearl I can take out of this 1 hour-long class, so I can move in tomorrow or Monday and just change someone's life with it, right? So, the preliminary evaluation gets my brain thinking a lot. The moment I hear I have a new patient coming in, I want to see how that new patient starts reacting. Now I do a lot of neurologic related stuff in my office, and so this is just a quick summary. I'm sorry, it's not a quick summary, it's kind of crazy. This is just a little oversight of something to think about for yourself when you have the patient that rolls in 10 minutes late for their new patient visit. Is it possible that neuroinflammation is going on in their life because they don't know how to read a clock, right? Is it possible that their left brain is so disorganized that they have no time orientation and they don't recognize that I live 20 minutes away, so I'm going to leave 10 minutes before my appointment, right? Some people are so inflamed that something that simple like the inefficiency or the inability to routinely show up on time is a symptom of neuroinflammation. Come on over here looking at handwriting, for example. As you're looking over their paperwork, and probably all y'all are probably fancy and use tablets. We're old school from 1986 and still use paper. But whenever I look at their handwriting, it kind of tells me some stuff about what parts of their brain might I be a little bit more focused on as I'm doing my neurologic section of my exam. And I do a lot of nutritional stuff, and I do a lot of muscle testing, and I do a lot of evaluation with questionnaires. But these types of things make me start thinking about their brain. And it's just normal daily behavior that we often take for granted, and we all just say, oh, that's Susie. She shows up 5 minutes late to her appointment every week, right? But does it mean something, and can we start helping to support that individual's performance in life by supporting their neuroinflammatory stuff. So before I've even touched this person and done an exam or asked a question, I have an opportunity to start thinking about what's going on in their brain prior to doing that. But then we got all these forms. How many of you use a symptom survey form of some kind in your office? Raise really high just in case. Perfect. If any of you don't use a symptom survey form, whether from Standard Process specifically or from some other place that you love, I would strongly, strongly encourage it. It's a phenomenal way of just getting a quick overview of a lot of stuff in people's lives. Each category is tied to a specific group of symptoms which would associate with common metabolic issues, whether it's blood sugar handling or adrenal stress or thyroid dysfunction or gut health or whatever it might be. But by having some type of questionnaire like this, the patient may show up and say, I'm here to see you because I have back pain, but they tell you all kinds of things about them, and now all of a sudden you have an opportunity to just discuss with them and say, I know you're here to crack your back, and that's fine, I can do that. But you haven't pooped in a week and a half. Can we work on that as well? Because that might be associated with this, right? And so we can start talking to people about what they're doing. Now, not to knock on SP's symptom survey, but it's not neuro heavy, right? It's very metabolic, general metabolic activity. So like blood sugar, basic hormone activity, general well-being, things like that. There are other questionnaires we can get to that are a little bit more heavy on the neuro side of things if we wanted to try and focus on a neurodegenerative place. But like we saw before, Crohn's is neurodegenerative, depression, anxiety are neurodegenerative, sleep issues are neurodegenerative. Could blood sugar handling be neurodegenerative? Could recent infections be neurodegenerative? Could be weight, whatever this might be. Waking up at night to pee, that could be a neurodegenerative issue. It could be prostate, but I would argue that the prostate can't work by itself in a vacuum, right? So there's other stuff going on. So I went through and tried finding peer-reviewed versions of neurodegenerative questionnaires, and because the concept of neurodegeneration is so ginormous, there's not a perfect questionnaire. There are some good brain assays and things like that. But here's one, for example, if you want to get bored and look up some other questionnaires that you maybe want to use in a more specific case rather than every new patient paperwork. But there's this cognitive assessment one. There's this one that does for like concussion related stuff. This is a very common one for like athletes. There's a depression inventory. There's an anxiety inventory. There's certain things we could look at if we were attempting to isolate and hone in on a questionnaire, because maybe that's how I practice. Maybe I use questionnaires as my primary diagnostic tool, my primary justification for therapy. Well, I need to make sure I have the data to back up what I'm doing, right? Because if the patient tells me they're depressed and I say, great, here's Nevaton, that technically works, but how do I know if I'm improving that person's life, improving their outcomes? Am I doing the most appropriate thing for them at the right time? Does that kind of make sense? So some questionnaires might be a way of looking into it. My new patient paperwork is 9 pages long. 4 of those pages are questionnaires that are like size 10 font, full page front. And it's a ton of stuff. And there's a brain specific one for neurotransmitters. Actually I guess there's a pediatric one, so that's for the small kids. But there's a brain specific one for adults, brain specific one for kids, and then a 2-page, very truncated down by metabolic systems in the body questionnaire. And if patients come in and they haven't filled that out, that's a problem to me, because it means they're not telling me what I need to know. It tells me they're probably not going to be compliant with what I'm asking them to do in the future, and it tells me that they don't care enough for me to lose sleep over their non-improvements. Okay, so I had the conversation with them. I'm like, look, what are you here for? I'm like, my back hurts. It's like, that's great. I can crack your back, and that's going to be awesome. I'm the best back cracker in town. This will be fine. But what's going on over here? And they're like, I didn't think that applied to me. I was like, well, and I get to have a conversation that talks about how the nerves of the body affect everything. And nerves could be affecting pain, about 10% of the nervous system. But what's the other 90% of those nerves doing as it relates to you and your function? So we can have conversations and talk about how I'm going to help them out in other areas. And maybe they just really want me to be the best chiropractor for them, and that's fine. I can accept that. But I don't want to lose an opportunity to help them improve systemically if they're willing to let me do it. So I brainwashed myself a long time ago to say a magic phrase. And I say this every time I ever talk with y'all, but I always ask a patient at the new patient visit, I say, if I had a magic wand and I could fix anything else in your health life in addition to this symptom here that you're coming in for, would you add to our list? And so the guy that comes in with back pain says, Well, yeah, if you had a magic wand, I'd love to sleep better, not have Crohn's disease, not have depression, lose some weight, whatever. And they allow me to now explain how important these questionnaires are for me and how I can help them out in other areas. But that one question helped me a ton whenever someone helped me figure that out. So now, let's go to some other stuff though. This is what I do a lot of. And many of you run labs in your own office. So many of you probably have a normal system. You go to Avexia, you go to Rupa, you might run it directly through Quest or LabCorp, whatever it might be, and you decide you want labs on somebody. And you write up your report and you say, please go get these labs. I'm going to propose to you that it's worth having some of these other tests that we're about to talk about in your new patient evaluation. Because these are heavily researched for neuroinflammatory things, and you will be shocked by how many come back out of range when you think this person is doing great. And they're tests worth doing. So, the first one would be C-peptide. Does anybody just know what C-peptide is, just out of curiosity? Raise your hand if you think you could give a good 30-second explanation of C-peptide without reading what it says here. Anybody? Do any of you already run C-peptide? Raise your hand if you run C-peptide. Dr. Alyssa does, because it's part of our new patient thing. Perfect. So C-peptide and insulin are both created by the beta cell together, and they're part of one big unit. So when blood sugar starts going up, your body says, go make insulin. But it can't make insulin on its own without C-peptide being tangled up with it. So now, blood sugar comes up, C-peptide and insulin come out, they cleave off of each other, and insulin within about 5 minutes goes back down, and C-peptide lingers for about 20 to 30. It's another indicator of how the body is handling things. And when C-peptide is lingering longer than it should, as evidenced by this very small text of peer-reviewed medical research here, where you can look at the citation later, studies have confirmed that cerebral small vessel disease, cerebral small vessel disease, these small microvascular neuroinflammatory things are higher in things like Alzheimer's disease and smoking and age and things like that. But this test is correlated with increased small vessel disease of the brain. Because when you have a bunch of floating C-peptide, even though they might go walking and lower their blood sugar through muscular activity, or they might have some level of medication like metformin or insulin that's pulling their blood sugar down, that C-peptide is the smoking gun in the room that's left over that says, this isn't quite as handled as you think it is. And when it starts going up, it can be indicative of neuroinflammatory conditions. So as part of our routine-ish blood work, whenever we determine someone needs a lab test, we include C-peptide every single time. And my goal is less than 2.2 on them. At 2.2, they start creating beta cell destruction, and they start having neuroinflammation in other research. I didn't cite it here, but just take my word for it. That's how they tell you to do it in the news, right? No, I'm just joking. So just take my word for it. There's the neuroinflammatory things that start happening. Once it's above 4.4, that's when you start getting the conversation of diabetic type activity. And this is routinely run through diabetic management as trying to see what's going on with beta cells. But it's an indicator of neuroinflammatory stuff. So if that's not on your list, maybe we add it and maybe we check it out on somebody next week or for the rest of your life. Hemoglobin A1C. We've all run this before, or we've heard of it. It's the common diabetes marker, right? Well, diabetes is an indication of blood sugar mismanagement. Most of the time, and when it's an adult onset or a type 2 version, it's because of long-lasting blood sugar mismanagement in someone's life, right? Very routinely run within the diabetic world, but at above 5.4, it starts changing the brain through neuroinflammatory pathways. So, if I'm measuring someone because I think they have a blood sugar problem, is it logical to think that blood sugar problem is leading to a neuroinflammatory condition? Yes. How many of you have heard of type 1 diabetes before? Raise your hand. How many of you have heard of type 2 diabetes? Raise your hand. How many of you have heard of type 1.5 diabetes? So that's someone who's an adult onset, quote unquote, type 2 diabetic, that over time has generated autoimmune antibodies to themselves, but it only started at the age of 40 or 50 or something like that, rather than the age of 7 like most type 1 diabetics. So type 1.5 diabetes is a merging of type 1 and type 2. And how many of you have heard of type 3 diabetes, often referred to as Alzheimer's, dementia, right? So neurodevelopmental brain issues can start when you're young, they can continue when you're older, and they can turn into neuropathology when you're an adult. Because most of us aren't seeing 40-year-olds with Alzheimer's, but we're seeing 40-year-olds with hemoglobin A1Cs higher than they need to be. And I just want to just for the sake of it, point out the LabCorp numbers that I took off the lab test here. Prediabetes, 5.7 to 6.4. We all recognize that it should be less than 5.7 according to the lab. Diabetes, this is all straight off their lab test, is greater than 6.4. And they say glycemic control for adults with diabetes is less than 7. Please keep that concept in mind when your patients who are on medication for diabetes come in and they say, I have diabetes, but it's controlled. The conversation they're coming in with is, my doctor said everything's fine because I've got 6.9 on my hemoglobin A1C. Okay? It doesn't mean everything is fine because I'm no longer creating neuroinflammation or that my beta cells all of a sudden work. They're just saying that due to the medication or the intervention we're doing, you are good enough. So how might we modify someone's inflammatory load that has a higher hemoglobin A1C or a higher C-peptide? What might we do? Anybody?
Adjust them.
Adjust them. Heck yeah, you're going to adjust them. If you're a chiropractor, you hopefully are adjusting them, right? What else might we do?
Change your diet.
What might you do, Lambert, if you said, I'm going to have you change your diet, your hemoglobin A1C's 6.7, you're trying not to be on metformin, you're trying to get some things under control, I want you to change your diet. And they say, great. I'm going to go home and eat some Cheerios because they're heart healthy. I'm going to eat some whole wheat bread because that's got all those micronutrients from the whole grains in it. I'm going to, how would you change my diet? I'm 6.7 hemoglobin A1C, 4.0 C-peptide, and I'm in your office and I say, please help me. I'm tired.
Carnivore.
You're going to cut all my carbs out by giving me carnivores. That's one way of doing it, right? So you might go carnivore, super low carb is what I'm hearing from your dietary modification there. Is there anybody that would do something different?
They went carnivore and got constipated.
Okay, so they went they went carnivore. Maybe they're now coming in saying, hey, my blood sugar is doing better on my continuous glucose monitor, but I haven't pooped in like a week and a half. Now what? Right? So there's different ways of coming about it. But hopefully we're thinking we're going to lower their diet, carbohydrates, as a management tool to help them in their lifestyle. So now, okay, well, let's go down that rabbit hole. So far, patient with diabetes comes in. We've decided we're going to adjust them. We're going to talk to them about dietary interventions wherein we're lowering their carbohydrates to whatever capacity we might need to, whether it's full-on carnivore, zero carb, or some variant thereof. Whatever they're doing is too high, so we're just pulling it down, right? Supplement-wise, let's brainstorm real fast. For someone who's got high hemoglobin A1C and high C-peptide, and you now are trying to help them interventionally. You've modified their diet. You've told them what to do. What's one supplement you want to do, Rod?
Paraplex.
Paraplex. Why would you do Paraplex?
It nourishes the pancreas and
That's right. Helps that pancreas to kick out more insulin more efficiently. It kind of heals it back up. It's like CPR to the pancreas, right? Paraplex is a great idea. Lower carb diet, something like Paraplex to support the pancreas activity. What else might we do? Diaplex, Gymnema,
Chromium complex.
berberine, metabol, pancreatrophin. Guess what? We've just named 8 awesome things we could do from standard process, and every single one of them is targeting the pancreas. Is there anything else we would do? Neurotrophin PMG, why? It's a blood sugar problem.
Inflammation in the brain.
There might be inflammation in the brain, right? So yes, we know how to handle a diabetic. We can change their diet, we can support their pancreas, we can give them herbs to balance out metabolic activity there, we can stimulate insulin production, we can stimulate receptor site activity. We can do a lot of things blood sugar wise, and we all defaulted to our favorites, right? The caveat I will give is, I hope we don't miss what's going on in their brain at the same time. And we might need to be assessing and supporting their brain right along with their blood sugar stability support protocol. Because if their neuroinflammation is manifest in both C-peptide and hemoglobin A1C, it's more than just a pancreas and insulin and blood sugar issue. Though that's obviously the thing that's causing it, right? Their blood sugar mismanagement is causing their brain to be on fire. And we have to get their blood sugar under control. But I propose it might be okay sometimes, muscly all the time, to shove that fire extinguisher up in their head also, and put that fire up there, take it away while you're handling the pancreas stuff. So remember I told you about that guy that reached in and grabbed his thing? His hemoglobin A1C was 13, and his C-peptide was 9. Okay? He had this huge amount of fire going on in his body, but he looked and acted and talked like a normal person. And you would have never known that he has this neurodegenerative condition just on the cusp of happening, and it took a head injury, something that all of us with kids have done in our life, where we reached in, grabbed something, and dang it, and hit our head and go on, right? But it was the fire that was smoldering in the background that got him, because it was a blood sugar problem, but it manifested as a neurodegenerative condition like Parkinson's. To help him, the doctor that was teaching that class said they had to fix blood sugar first, while at the same time calming down inflammation of the brain, and his Parkinsonian presentation dramatically shifted. Because it wasn't an L-DOPA issue in the substantia nigra, it was a brain on fire issue that got triggered with his cerebellum. And so they lowered inflammatory issues with the cerebellum, and his tremors changed. And they had to fix his diet. Interesting stuff like that, right? Who would have thought? Guy walks in and is Parkinsonian, and it's a blood sugar issue that triggered it all to begin with. So, how many of you have run a C-reactive protein in your life? Okay, there's two types, regular C-reactive protein and C-reactive protein high sensitivity. This one's my default one that I run, so I picked it for our slides. But C-reactive protein is a reflection of an interleukin-6, loosely. So it's kind of like a cytokine manifestation. Interleukin-6 typically is the inflammatory cytokine that happens after acute injuries or stress-related responses or whatever, right? So now all of a sudden we've got C-reactive protein. On the lab, they want us to be less than 3 to be in the average range. I love it to be less than 1. C-reactive protein, along with hemoglobin A1C, are useful prognostic markers for detecting cognitive dysfunction. I thought that was an interesting one. Because remember, you think about C-reactive protein for inflammation, we think about it for infection, we think about hemoglobin A1C for diabetes, but this paper states specifically cognitive dysfunction. Both of those are great markers as predictive outcomes for them. Homocysteine, we often think about that as a heart marker. Doesn't have to just be heart, it's how your body metabolize stuff, methylate it out, clear it through. It revolves around a lot of the methylated B vitamins, like the MTHFR stuff and things like that. But when homocysteine starts going up, once it goes above 14.5, 15 or so, it's a sign of inflammation. Doesn't just mean heart-related stuff, could be any place. So this particular study talked about how homocysteine is strongly related to neurodegenerative and neuroinflammation conditions. Talked about how it's associated by messing with the tau bodies and tau phosphorylation. So something to be cognizant of is some of these markers that we sometimes just default to, of like, oh, you're got high blood pressure, you're overweight, I'm going to run a cardiovascular panel on you. It doesn't mean it's only cardiovascular stuff that we're analyzing, and it can be neurodegenerative. Cool. Have any of you ever run a T and B lymphocyte subset? I'm the only weird one in the room that runs these. This test, and I apologize for not giving you a whole explanation of the functional ranges and everything. This test is a test commonly ran on AIDS patients. So every time I run, not every time, I used to get this call from the CDC all the time where they'd call me up and say, hey, how's Johnny doing with his AIDS? I'm like, what are you talking about? And they're like, well, we got this test from the CDC or from LabCorp that said you ran a TB lymphocyte subset on him. And so we just always follow up with the practitioners to make sure that the guy is not transmitting and going out and he's doing okay. And I was like, no, man. I remember I'm the chiropractor you talked to last time. And they're like, oh, yeah, okay. I remember you do that weird thing looking at their immune function for stuff. Okay, that's fine. I just want to make sure it wasn't an AIDS epidemic going off in Cyprus or whatever. So this test is routinely run as an evaluation tool to evaluate immune function of the innate immune response, not for diagnosis. So like if I wanted to know if someone had COVID, I could run a blood test, do a COVID antibody test, and that would say, yep, you got IgG for COVID, you have it. Or you had it, one or the other, right? This is more just how are the CD4s versus the CD8s versus the natural killer cells. It's an adaptive immune response that fluctuates to give me an idea of how things are working. But it's a loose interpretation of how immune system and inflammation systems are being handled in the body. And if you can imagine a seesaw, T cells and B cells alternate with each other. And when someone's stuck like this, that's a problem. If I ever feel like someone has been to everybody and they're finally shown up in my office and they come in with a big old stack of blood work and they look at all kinds of things, this is the test I will run first. Because they've already had everything else. I'm going to look at your immune system and your inflammatory system and see kind of what's going on. And this test helps a lot by giving inflammatory markers a data point that I can look at. If you like spending more money of your patients, there's another test called a lymphocyte map run specifically by Cyrex, which is this, but on steroids. Like, it's got more stuff added to it. And it's a phenomenal test, but it's just like an $800 test, and I have a hard time doing that when they can get their insurance to run this one a lot of times. Or at least, this is like $250 in my office, this is like $800 in my office. And this usually works. But something to consider. If you ever want to have more conversations about that test, it's a good one. I had a hard time putting this slide in because I didn't want to go down the rabbit hole of what it means. But also I wanted to make sure you knew that this is available as a really cool test to try and find out about someone's inflammatory load. Phenomenal test. And if you just have someone who's stuck and you're like, man, I know you're an autoimmune patient somewhere and your body's not working right, but I can't figure out where it's coming from and none of the other doctors can, and your scans are all normal and everything looks fine, that's why I run this test on those people. Because it gives me a picture of what is their immune system doing in the balance, and then we just help support that. Cool. Other things, if you do other types of functional testing, we mentioned heavy metal type things in the back earlier as a neuroinflammatory thing, gut-related stuff. Like, I run GI maps on people. I think they're a phenomenal test. And then Cyrex has some uniquely specific tests. This one here will look at autoimmunity to the brain barrier, or the gut-brain barrier, so zonulin and aculunin and how the antibodies affect those. And then these are going to be general autoimmunity to a bunch of tissues in the body, and neuroautoimmunity specifically, so myelin and synapses and dendrites and things like that. So they're neat tests. They give us a lot of good information, but they're just a tool. That's what we got to remember. Y'all are the clinicians. Y'all are the brilliant people that know how to help these individuals. But as we do background through their history, we have them fill out questionnaires, we do some labs, we identify where the inflammatory process is coming. Yes, sir?
What's your preferred way of determining heavy metals? Is it through hair tissue or blood?
This is a great question. I actually don't do a ton of heavy metal testing through labs. I muscle test a bunch of stuff, and I'll check vials. But if I really want to do it, I would do a urine provocation test, to where I'll have them take a bunch of DMSA and then urinate over a 24-hour window and see how urine excretes out their metals. But I might do 5 of those a year, maybe. It's not a very common thing that I do. And it's usually by patient request. When they come in and they're like, hey, I really want to just do a heavy metal test, what do you got? And we'll work on that. Good question, though. Any other thoughts or questions? I feel like we're being quiet in the crowd. So I'll do the wave. No, I'm just joking. Maybe. Do y'all need some RNA?
Yeah, pass it around.
We'll pass some RNA around. That's good stuff. That's what I took whenever y'all were doing your brainstorming session. I think I'm up to 24 of those this morning. Yes, sir.
What's your preferred lab for GI map?
Preferred lab for GI map? I usually do like their GI map with zonulin. But I go.
Like which company?
Oh, I use Rupa. I go. So, are you familiar with Rupa? Okay, yeah. So I just go to Rupa and order it through there, so I don't have to have kits or anything on hand anymore, because it's worth it for me to pay them the extra $40 or whatever it costs to do that.
On companies like Rupa and others that kind of consolidate the different lab companies,
Right.
and make it an easy portal to use, how are they making money?
I have no idea. No idea. I mean, they charge me a little bit, and maybe they're just doing it off of volume for everybody else, but I have no idea what their business model is. I'm just glad I don't have to have all the kits in my office anymore. Because I used to do more Cyrex testing than I do now, and those kits would just expire, and I'd get so frustrated because I'd walk in and say, hey, we're going to do this awesome test with you today, and I'd grab a kit and it'd say expired 6 months ago. I was like, oh, oops. Well, we'll order this kit and get it to you in a month. So now Rupa just sends them all, and I like that process. It's easy. Any other questions? Doing okay? Yes, sir.
Why do you use Rupa over Avexia?
So I do my blood test through LabCorp with Avexia because it's cheaper, and then Rupa for like Cyrex and GI Map because it's cheaper than Avexia. That's all. It's just silly, but that's why I do it. Any other questions? I'm an open book, man. Y'all can ask me anything you want. All right. So this was the hardest part to come up with because I am so heavily involved in applied kinesiology, muscle testing things on a daily basis. So I was trying to come up with what's something y'all could do tomorrow if you've never muscle tested someone before, or if you don't have a desire to muscle test anybody, right? So I tried coming up with some ideas on how y'all might be able to take some of this stuff and use it with your normal physical exam, whatever that physical exam might look like, right? So I'll have a brief conversation about a manual muscle testing concept in case you manual muscle test and you're not familiar with it. And then we'll go into some other things. And then more importantly, if we have time, we're gonna practice on each other. Because that's boring if you come learn some good things. How are we on time, by the way, Christy?
We're good. I was gonna say, if you wanna go until 10:30.
I don't know what time it is. 10:06. All right, 25 minutes. So can you just stop me in 9 minutes?
Okay.
Thanks. I don't know why 9 minutes, but it sounded better than 10, right? So manual muscle testing. I do a bunch of manual muscle testing. Can I borrow this chair from you, Lori? The one right next to you? All right, can I get a guinea pig? Anybody with an arm that doesn't mind me putting them right in front of everybody. Good to see you. Thanks for being a guinea pig. That light's going to blind you, so I apologize. But manual muscle testing, normally in my office, they're lying on their back, and I do a bunch of tests. And I test all over their body. I do some straight arm testing with things, but I do a lot of traditional applied kinesiology where I'm testing legs and piriformi, yeah, whatever it might be, right? Today I'm just going to demonstrate one simple concept. And that is if I take this arm and I do a manual muscle test for this middle deltoid, and you just push straight up to the sky. Good, and we have a good strong arm. We would expect it to be strong, right? If I approximate or squeeze those muscle fibers of the deltoid pretty aggressively, and then I retest that arm, push up, I should get a weakening effect. That's a neurologically correct muscle. So let's just think about this for 1 second. If we go back to neurodiagnosis class and I hit her knee and she kicks once and comes back, and it's an appropriate intensity and duration, we would call her normoreflexive, right? If I hit her and she kicked for 5 minutes, we would say hyperreflexive. And if I hit her and she didn't move at all, we'd say hyporeflexive. In manual muscle testing, there's a similar concept. I have an arm, push up, she appears strong. She's not hypotonic, she's normotonic or hypertonic. If I now challenge her muscle and I check it again and she goes weak, I know it's a normotonic muscle. That's a neurologically stable connection. When I'm doing my manual muscle testing and I'm screening for things, hypothetically, what if she was hypertonic? I test her and she's strong and I think, yes, she's strong. And then I go and I test her and she's still strong. I think, oh, we might have a neurologic imbalance somewhere, and I might need to do something about that. So it's part of my physical exam. I check for this concept called autogenic inhibition, and I look to see if that's neurologically stable or not. When we break up later and we play with this, if you've never muscle tested, don't stress about it, just try it out. And if you do muscle test a lot, see if you can find a muscle that's strong, that when you activate it, it changes and goes weak again. If for some reason it doesn't, because I do classical applied kinesiology stuff, I take pills. I've got a pill set up like this on my shelf as well at the office. I take a pill out, I put it in their mouth, well, I put it in their hand, they put it in their mouth, and then I retest to see if that neurologic integrity has been restored to normal. And it's a challenge that I do in my office to try and help identify neurologically stable muscles, normotonic, versus hypertonic or hypotonic muscles. Quick demo there. We'll go through that again later. Thank you very much for that. That was so good. I'm glad your deltoid works properly. Thank you for that. All right, so that's something that if you muscle test, it might be something worth playing with. What if I do some type of muscle testing that's not really like classical AK, but it might be more like nutrition response testing or some type of CRA type protocol? In a lot of these processes, we look to see if someone's blocked or switched, right? You've heard of that concept. You take an arm, you put a finger somewhere, or you put a magnet somewhere, or you do something, right? And if their response is not what is anticipated, they might have neurologic disorganization. We might call it being blocked or switched. We might think neuroinflammatory processes going on in that situation as well. Now, it could just be that their pancreas is jacked up, or it could be that their liver needs to be declogged or whatever, but it could be neurologically in tune as well. Cool? All right. How many of you have been pulled over by the cops for drunk driving before? Raise your hand. No, just joking. Just joking. So, you've seen this test on the movies. You just walk in a straight line. You hope that someone's balancing correctly and not falling over, right? This is a test you can do in the office. And you have them stand there and you're like, walk straight ahead. And they do this. And then you're like, great, do it again, but now with your eyes closed. And they're like, you're like, great, you've got a neurologic problem. I like to challenge stuff with my office by putting things in their mouth and having them retest it. And it's shocking to me to see how much one supplement can change someone's physical exam findings. And it's shocking to the patient because the patient goes, what was that? And I was like, well, you just earned yourself a bottle of that, whatever that is, because it made things better in your life. So hypothetically, if I start walking and my eyes are closed and I start stumbling somewhere, I have a slew of neurologic supportive things I can do to someone. So let's brainstorm out loud, and you might want to take some notes because some people like some things more than others. But what are some things you might do to support someone's neurologic presentation if during a physical exam it's not working like you want it to? What's one thing? We all just passed around what? RNA. RNA is a phenomenal one. If you just have some neurologic stuff not working for you, and you're just trying to see if it'll help out, that'll do better. Manual muscle testing often gets back to normal with RNA. Balance and coordination stuff often gets better with RNA. In a second, we're going to have everybody stand up and stand on one foot and close your eyes. And if you can't do that for a long time, we're going to put RNA in your mouth and see if you can do it better the next time. We're going to play around with stuff like this because hopefully you'll see that nutritional stuff can support brain function. So we talked about RNA. What's another thing we might consider in this scenario?
Neurotrophin.
I'm sorry?
Neurotrophin.
Neurotrophin, that's right. Neurotrophin is another great one. Why? Because it's nerve-derived DNA to help support that nerve system that's possibly inflamed. What else can we think of?
What about omega-3s?
Omega-3s, I love it. In fact, I love tuna fish oil. It's my favorite omega-3 from Standard Process. I use that a lot because I like the DHA content in it. But yes, essential fats are a big deal for supporting neuroinflammatory things. The omega-3 to omega-6 ratio is jacked up in everyone in America. Our ratios are too skewed. So we need more omega-3s, less omega-6s to help neurocognitive activity improve. So we've got tuna fish oil, or omega-3s, I'm sorry, omega-3s, because it could be O-Prima, it could be cod liver oil, it could be tuna fish oil, it could be some different ways. We've got neurotrophin, we've got RNA. What are some other things you like specifically in your practice to where if you're like, man, I want to help this person's brain lower some inflammation and do a little bit better? What else would you say? That's not Christy who runs the company. Turmeric. Turmeric forte is a great one, especially because it's got the fenugreek stuff added to it, so it can help bypass the blood-brain barrier and get in where other things couldn't. Anything else come to mind? Boswellia is another good one. I'm sorry, what did you say? Neuroplex. How many of you think Cataplex E2? I like Cataplex E2 for brain-related stuff because it's a what? Vasodilator, and it's going to help get nutrition into places. So sometimes whenever I'm looking at nutritional stuff and I muscle test things and I put stuff on their mouth and I'm just not getting the result I'm looking for, I'll grab some weird ones like Cataplex E2, which isn't that weird. It's got a lot of selenium in it, helps with vasodilation. It's good stuff. I like Orchex. Orchex is another one. We sometimes think about Orchex just as like a calmer downer, especially when coupled with Mintran and it becomes Minchex. But Orchex helps grab things and pull it through the blood-brain barrier. So I like that idea from a delivery system. Let's see, what else do we like here? What's some other ones you like? What's the new one that just came out that's probably going to be on all of your lists? Neurogenics, right? So this one's got a bunch of herbs in it, like the turmeric and the burpulpa and all the boswellia. Like it's got its good.
And go to Cora.
There you go. That's why she's here. She's going to talk a little more about it. I started using it in the last month or so. It's fun. I like testing it on people, and in fact, I'm getting off topic here. I was doing an exam on somebody, and he comes in and has complete neuropathy through both sides of his legs, and he's got 2 toes amputated from diabetes, and basically he was just walking like this, right? So he's got a weird steppage, imbalanced gait from his neuropathy. And he was talking about it, and I'm just sitting there, I'm muscle testing stuff, but his muscles are fine. Like his glute max, or glute medius works, his TFL worked, his quad worked. And I'm like, this is so weird. You have normal responsive muscles, but you have no sensory activity. And it's like, no big deal. Motor's only 20% of the nervous system. Sensory is 80% of the nervous system. So okay, let's deal with some sensory stuff. So I started doing like light touch, just like we did in school. Does this feel like this? Does this feel like this? And I just started going through the process with him. And he's like, no, this side doesn't work, and this side does. And then I got to cold. He did not feel cold at all from his knees down. Like I just put ice packs on him. I had him put Neurogenics in his mouth, and every one of those sensations came back. Wow. It was the craziest thing that I've ever seen in my life, because I didn't do my neuro rehab, I didn't adjust him, I didn't put lasers on him, I didn't do any of that. I said, put this on your tongue, and this literally happened like a week ago. And as I'm doing it, I'm like, I should have recorded this for this lecture I'm about to give here, because this would have been freaking amazing. But I didn't do it, and I was just like, put ice on me, and he flinched. I was like, why did you flinch? He goes, I don't know, it was cold that time. I was like, well, cool. And he's like, what is this I'm doing? I was like, I don't know, but you're about to take 9 of them a day. That's the guy that I was thinking of that is 9 a day. That was that person. So I gave him 9 a day, and I warned him. I said, look, this product's a little bit expensive, but we're going to crank some neuroinflammation out of your body. So here's 9 of these a day for a while, and I haven't seen him yet, so we'll see what happens. But it was one of those things where he regained sensory input with light touch, cold, and sharpness. He didn't get vibration back at all. He still couldn't tell when I stopped the tuning fork and when I didn't. But it was just literally like a standard neurologic exam that you guys all learned in Tri-5 or whatever your chiropractic school is what I did with him. So great stuff that you can do. And then I just put it on his tongue and watched to see what happened. So let's pretend we're doing a gait test. How much time do I have left?
You're at that time.
Perfect. We'll go 1 more minute. So, so let's pretend we're doing a gait test. You can provoke them by like pushing on them and doing stuff, but don't like assault anybody. Just test it out. You're seeing what the nervous system does. This one here, can I borrow you again? We'll just do a quick demonstration of what this looks like. You did so great. Can you stand right here? Close your eyes. Push really hard on me. Keep pushing, keep pushing, keep pushing. Okay. That's a cerebellar rebound test. That was normal. What if she would have gone, whoa? Not normal, right? What if, as I push her, she goes down? Thank you very much for your help. I appreciate that. So something like that. And then I just challenge it. It's a small, simple test. But if the test doesn't work, neuroinflammatory stuff is probably present. Last one. This is one we talked about. We're all going to stand up. We're going to do a 1-foot balance. We're going to close our eyes. We're going to see how long we can do that. If for some reason we can't do that very long, we're going to put RNA in our mouth. We're going to test it out again. We'll do the other side. And just you with your partner that you brainstormed with earlier are going to have an opportunity to test some of these different things. Does that make sense? That's a boring test. Nobody really wants to do that. You basically just shake your head a bunch and then see if you can do something fun. Like, I'm shaking my head. Can I touch my toes? Oh, I fell over. Right? That's a neurologic imbalance. We put something on their tongue. We test it out and see if we're making clinical outcomes. I guarantee you, if you show the patient that they can't do something and then you give them an opportunity to modify that and they can do it a lot better, they love it. And they're like, no one else is doing what you're doing to help me. You're like, yeah, because nobody looks at you like I look at you. So we're going to make some changes, and it's going to be awesome. We'll do the case studies afterward, like after Steve talks. So these are the tests we talked about a little bit. What we're going to do for the remainder 10-ish, 15 minutes or so, stand up, get a partner, pick whichever test you want to do, play with it. If it doesn't work, come grab something up here on our array of fun and see if you can get it to start working better by just having them suck on it in their mouth. Okay? So once again, maybe I pick 1-foot balance. Alyssa, can I borrow you for 1 second? So I'm just going to demonstrate one thing real fast. Let's say I'm going to do 1-foot balance here. Stand up on 1 foot. Go ahead. Close your eyes. See how I'm here to make sure she doesn't fall over? It's literally just like you're in school. Please don't walk away and say, oh yeah, you're fine. And then she falls over and hits her head on the table or something, right? Does that make sense? So just be safe with whoever you're partnering up with so nobody gets hurt, but we're going to play with it. So take some time, test it out, come check out whatever you want to look at here supplement-wise, put it on their tongue and look for change. Let's all be amazed and impressed with ourselves.
I don't